This is going to be our lecture for altered male and female reproductive. Here are the objectives that you should be able to do by the end of this lecture. We are going to start with the female reproductive system. So we're going to look at the organs that make up the system itself. So we have our female reproductive internal system and external system. So for the internal system, we have the organs that are the ovaries, the uterus, fallopian tube, and the vaginal opening. For your external structures, we have the vulva, labia, and clitoris. Our main functions for the female reproductive system help with things like ovulation, which helps with egg production, fertilization, which helps with production of a fetus, menstruation, which helps regulate the uterine lining, which helps with the process of reproduction as well, pregnancy itself, and lactation regarding the hormones for lactation. For your nursing assessment for reproduction of the female, we'll want to get a good history, paying particular attention to patients' menstrual cycles, any problems with lack of bleeding or over bleeding or too much bleeding, an obstetric history, how many children they've had, if they've had live births or if they've had any miscarriages or fetal demise. Sexual history, if they have sexual intercourse with multiple partners, one partner, is it protected using condoms or other barrier methods? Do they have any medication history, taking any contraceptives or medications for any STIs? Do they have any family history related to any reproductive organs or system? Then we want to do our exams. So we'll do a pelvic exam, abdominal exam, looking at things like the cervix, doing those pap smear exams or diagnostic testing, looking at breast exams, so teaching them how to do a self breast exam, asking them how often they do that, and then looking at things like a mammogram as well for screening. For our cervical screening on our female patients, these are typically done every 3 years once the patient is sexually active, usually between the ages of 18 to 29 years of age is where we will usually start that, depending on sexual intercourse beginning. This helps to detect cervical cancer or HPV, which can cause cervical cancer. After 30 years of age, we really want to make sure to do a co-test for HPV since we are at higher risk for this as females. HPV is typically carried by men, and men do not have any symptoms of HPV, so they typically can pass this on to female partners with unprotected sexual intercourse. So we utilize cervical screening. There you can see they insert a speculum, open up that vaginal canal so that they can identify and visualize the cervical opening, the bottom of the uterus, and that they're able to do a visual inspection, looking for any signs of potential cancer or infection, and then they will do swabbing and send that down to look at the cervical cells under a microscope. Again, this is done every 3 years. It used to be done every year for a well woman exam. Now they've switched to about every 3 years, as long as you don't have any signs and symptoms of cervical cancer, you have safe sex practices, not multiple partners or anything like that. Okay, so we're going to talk about contraceptives. Contraceptives are different methods that are used to prevent pregnancy. They do this by either blocking fertilization or actual implantation after fertilization. Some regulate hormones to help control menstrual cycles in females. They can also be used off-label to help with managing severe acne or treating painful or heavy periods. For our mechanism of action for different types of contraceptives, They can either prevent ovulation, which helps to stop the egg from being released. They can thicken cervical mucus, which helps to block sperm entry. They can alter endometrial lining, which helps to prevent implantation, or they can create an actual physical barrier, which helps prevent the sperm from coming into contact with the egg itself. For our hormonal methods, these typically are your like pill medications or your transdermal patches, injectable medications, or implants like a vaginal ring or an implant rod. These use hormonal methods to alter hormone levels, which in turn affects ovulation and decreases the risk of getting pregnant. For our intrauterine devices like IUDs, these are typically small T-shaped devices that are inserted directly into the uterus. These can help with hormone regulation as well. They can be infused with hormones, or they can just block the lining of the implantation of the sperm to egg method. For your barrier methods, these will be things like your female or male condoms, spermicides, or a diaphragm or cervical cap. These help actually physically block the sperm in the ejaculate from reaching the egg during ovulation. These are also the ways that we can help prevent and protect against STIs with those male-female condoms. But there is a risk of latex allergy. More permanent methods would be surgical methods. These would be things like a vasectomy or a tubal ligation, where the fallopian tubes or the vas deferens are cut, tied, maybe cauterized, and surgically blocked. Typically, this is permanent, and pregnancy doesn't occur afterwards, although it can occur where those can be, either reversed intentionally or they can kind of fuse themselves back together on accident. We do have some natural methods or behavioral methods. These would be things like ovulation tracking, avoiding intercourse during the fertile window, and the withdrawal method. But these require very strict consistency and have a very high failure rate. For our contraceptives, some of the So we're going to talk about infertility. Infertility is typically considered to be an inability to conceive or get pregnant after 12 months of regular unprotected intercourse, or after 6 months if the female is older than 35 years of age. It can result from different factors relating to the female having issues, males having issues, or combined factors where both individual parts are not compatible with each other. It's fairly common. It affects, about 20% of couples. It's becoming a little bit more common because people are talking about it more and more. But it typically, they look at primary infertility being somebody who has had no previous pregnancies, and secondary infertility impacting a couple or an individual who has been pregnant prior but now has difficulty conceiving after. Usually, female factors that impact fertility would be things related to ovulatory disorders. These are the most common. So this is something where an individual either isn't ovulating or they're having underproduction of eggs. So this can be things like PCOS or polycystic ovary syndrome, which we talk about in this lecture. Hypothalamic dysfunction, so problems with the hypothalamus resulting in endocrine dysfunction, releasing those eggs, premature ovarian insufficiency, and those types of things. It can be a cause from tubal or uterine factors that either block or damage the uterine lining or tubal, the fallopian tubes, this can lead to preventing fertilization from occurring. So things like that would be endometriosis, which we're going to talk about in this lecture, scarring from previous surgeries, pelvic inflammatory disease, or different fibroids or polyps. There can be some cervical factors that lead to infertility. These can be things like infection, abnormal cervical anatomy, or thick cervical mucus that kind of impacts the sperm from entering into the cervix and uterus. Male factors typically will include low sperm count, or the sperm has an abnormal morphology, which is the structure of the sperm, or poor motility, to where they're not entering into the cervical opening and meeting the egg. Other things like low testosterone or drug and toxin exposure can also impact infertility in a male. Sometimes both partners contribute again, and sometimes that cause is not found. Sometimes there's just an incompatibility with the sperm and the egg. This is about 20% of cases where they just don't really have a good solid reason, and it leads to unexplained fertility. In order to diagnose infertility, what we do is we do female testing, we'll do an ovulation assessment, hormone testing, typically a transvaginal ultrasound to look at the anatomy of an internal reproductive organs on a female. They'll do a semen analysis on males, and typically we'll do hormone level testing as well to kind of look at problems or barriers for pregnancy. For patients, a lot of lifestyle modifications like normalizing their weight, reducing stress, avoiding drugs, smoking, alcohol, and then really timing that intercourse with ovulation is usually the first step. Some medications that they can use would be things like metformin to help with PCOS, hormone therapy for patients who are low in estrogen or testosterone, or medications that help to stimulate ovulation. There are procedures that can help with decreasing infertility and lead to pregnancy. These would be things like IVF, in vitro fertilization. This is where eggs are retrieved, fertilized externally, and then that embryo is transferred into the female. IUI, or intrauterine insemination, is another procedure that can occur. This is where sperm will be placed directly in the uterus and typically will occur near ovulation. If we find a problem that can be managed with surgical management, this would be things like removal of fibroids or polyps, or treatment of endometriosis, or any type of tubal reconstruction, then that could be also a stage or a step in managing infertility. For the most part, nursing considerations are to provide emotional support. Oftentimes infertility causes grief, depression, relationship strains, so we really need to educate the patient on how to manage their emotional needs, teach them how to use ovulation kits correctly so that they can identify when they're ovulating and that risk or that chance of pregnancy can be higher, promote healthy lifestyle changes, discuss options related to in vitro fertilization, surrogacy, using donor sperm or donor egg, encourage open communication, maintain that privacy and confidentiality, and just really educate over all procedures that could be used. Okay, we're going to briefly talk about the menstrual cycle. The menstrual cycle is typically a 28-day cycle that includes hormonal changes and is controlled by the hypothalamus pituitary ovarian axis. So if you recall, the hypothalamus stimulates the pituitary to release hormonal hormones that help with that hormonal cycle and work on the ovaries. Its main purpose is to help prepare the uterus for pregnancy and helps to release an ovum or an egg. There are 4 main stages, so we'll talk about those. Stage 1 is typically days 1 through 5. This is the menstrual phase. This is where the cycle begins and the endometrium sheds, producing menstrual bleeding. During this time, estrogen and progesterone levels are very low, and so that hormone levels dropping helps trigger that shedding to occur. During this time, patients or females may have really low energy to those super low energy due to those low hormones. They also will probably have possible cramping. Typically, NSAIDs like ibuprofen will help decrease prostaglandins, which help decrease uterine contractions. Days 1 through 13, this is the follicular phase. This is when the pituitary releases the FSH or follicle stimulating hormone. This helps to stimulate follicles in the ovary. One follicle typically will become dominant and helps to be matured into an ovum. During this, estrogen rises to help stimulate that follicle growth. Estrogen helps to rebuild the endometrial lining, and so high estrogen in this phase triggers the next stage, which is ovulation. Typically on day 14, ovulation occurs. This happens due to a surge in the luteinizing hormone, which causes that follicle to rupture. This releases the ovum into the fallopian tube. During this time, cervical mucus becomes thin, clear, and kind of like an egg white consistency. This is ideal for sperm mobility and motility up into the egg area. Ovums typically survive 12 to 24 hours, and sperm will survive up to 5 days. So pregnancy can occur several days after intercourse and can occur before ovulation occurs, since that sperm will be hanging out waiting for the egg to come down. Days 15 to 28 is your luteal phase. During this time, the ruptured follicle becomes the corpus luteum. This secretes progesterone and a little bit of estrogen, which helps to stabilize and thicken the endometrium for implantation. If pregnancy occurs, that embryo will start to produce human HCG, which helps keep the corpus luteum alive and helps to maintain that progesterone until the placenta starts to form and take over. If pregnancy does not occur during the luteal phase, the corpus luteum degenerates, the progesterone and estrogen drop, and that endometrial lining breaks down, which leads back to that menstruation starting again. Typically, the luteal phase is very consistent at about 12 to 14 days, and oftentimes your symptoms of PMS or PMDD occur due to the progesterone shifts. So for your hormones, estrogen helps to build the lining, progesterone preserves the lining. A drop in both of those hormones makes the lining shed. So that's kind of that circle or cycle. So it is a cycle, 28 days, and that's kind of how that occurs there in the body. Okay, so we talked about the typical menstrual cycle. Now we're going to talk about some disorders related to the menstrual cycle. We have amenorrhea. This is an absence of menstruation. This is broken up usually into primary amenorrhea and secondary amenorrhea. Primary amenorrhea is not having a menstrual period begin by the age of 15 to 16. Usually this occurs due to endocrine disorders or congenital abnormalities and disorders like Turner syndrome. Secondary amenorrhea is an absence of the menses for 3 months or more after an individual has previous normal menstrual cycles. Our most common cause is pregnancy, so that is a type of amenorrhea. But other causes can be things like excessive stress, abnormal eating disorders, thyroid disorders, PCOS, or excessive exercise. So for patients, we always want to rule out pregnancy first and then look at other causes like hormone regulation, nutrition, stress, or weight loss. For dysmenorrhea, this is painful menstruation. Menstruation typically can have a little bit of pain, but this is a severe pain. This usually will have severe cramping, really bad low back pain, nausea, vomiting, and just pain that isn't treated with typical medications, heat therapy, and light exercise. For this can be caused due to excessive prostaglandins, which lead to excessive uterine contractions, or it can be due to things like pelvic inflammatory disease, fibroids, endometriosis, or other hormonal causes. For menorrhagia, this is excessive heavy menstrual bleeding. This is where an individual will soak through a pad or a tampon every 1 to 2 hours or have bleeding that lasts for more than 7 days. This can be typically caused due to endometriosis, coagulation disorders, hypothyroidism, or uterine fibroids, which is the most common cause. For your patient with menorrhagia, we want to assess for things like anemia, monitoring hemoglobin and hematocrit, and discussing some medication options that might help decrease the flow. For our metrorrhagia, this is intermenstrual bleeding. This is where bleeding can occur between the normal menstrual cycles. This can be due to ovarian cysts, endometrial polyps, different STIs or infections, hormonal fluctuations, or cancers. For these, we want to encourage patients to have their pelvic exams and pap smears and then track any patterns of bleeding. For your patients with PMS, this is premenstrual syndrome. This is a cyclic physical and emotional symptoms that can occur during the luteal phase and typically resolves with menstruation. So this is kind of your before bleeding kind of symptom changes. So what we'll see a lot of is irritability, mood swings, fatigue, headaches, bloating, breast tenderness, and those types of things that will occur during that luteal phase. With our PMDD or premenstrual dysphoric disorder, this is a severe form of PMS. This has major mood disturbances like anxiety and depression. And for these patients, we may do something like medication control like SSRI, nutrition support like vitamin B6 or magnesium, or lifestyle changes, exercising better, increasing exercise, better sleep habits, and decreasing caffeine. Okay, so for your patients, we will talk about menopause. Menopause is where the menstruation permanently stops. This is diagnosed after 12 consecutive months without a menstrual period, typically occurring around age 50. This is caused by a decline in the ovarian function and related to a decrease in estrogen and progesterone. This is a natural normal life progression, so it occurs in all females around that age and leads to no more menstruation. There are a couple phases that we'll lightly talk about. There's perimenopause. This is usually about 2 to 8 years before menopause occurs. Patients may see irregular menstrual cycles, fluctuation of estrogen levels, and so they'll have those symptoms start, like hot flashes and mood changes. During menopause, those ovaries stop releasing eggs, those estrogen and progesterone levels are very low, and those periods permanently stop. Then we have postmenopause. This begins after 12 months with no period of occurring, and this is where those risk factors due to low estrogen levels increase. So risk of osteoporosis, cardiovascular disease, and genitourinary syndrome occurs. For your common symptoms of menopause, again, you'll hear a lot of patients in menopause or in perimenopause talk about hot flashes, night sweats, maybe some palpitations that would be caused by low estrogen levels. They may have genitourinary symptoms like vaginal dryness, recurrent UTIs, painful intercourse. They may have psychosocial and emotional symptoms like those mood swings, irritability, sleep disturbances. They may have musculoskeletal changes like decreased bone density and a higher risk factor or risk for fractures. So for our patients, we'll do a lot of lifestyle modifications. Hormone replacement therapy can be effective, but we want to use the lowest dose for the shortest duration, since hormone replacement therapy can lead to different types of cancers. Okay, here are the objectives that we're going to talk about for this chapter. Okay, so now we're going to talk about some reproductive tract infections. RTIs are infections of the reproductive system that are usually caused by some sort of bacteria, a virus, fungi, or parasites. They do include vaginal infections, STIs, and pelvic infections. So we'll talk about some of those separately, but for the most part, they affect the vagina, the cervix, the uterus, the fallopian tubes, the ovaries, and can affect male reproductive organs like the prostate, testes, and the epididymis. So the reason why RTIs matter is because these are typically the leading cause of infertility, which we talked about, especially things like chlamydia, gonorrhea, and pelvic inflammatory disease. They increase your risk for ectopic pregnancy. They can increase risk for preterm labor. They can increase the risk and acquisition of HIV, and they can cause quite a bit of psychosocial stress. So we really want to make sure that we assess them early, treat them, and provide non-judgmental education. So we're going to talk about some of the infections, but we're going to talk about chlamydia, gonorrhea, other STIs. We will talk about HPV, HIV, hepatitis, and those kinds of STIs as well. And then we're going to talk a little bit about epididymitis and prostatitis. Other RTIs that we are not going to go into in this lecture, but are in your ATI teachings and in your book, are things like vaginitis, which is a bacterial vaginosis or a vaginal infection. This is due to an overgrowth of bacteria that is anaerobic. There is a candidiasis or yeast infection. This is caused by a Candida albicans overgrowth. This is a fungal infection. This is typically found after antibiotics or in diabetics. This can cause a thick white cottage cheese discharge, itchiness, redness, and usually your treatment is an antifungal cream or fluconazole. For trichomonasis, this is a protozoan parasite. This causes green, yellow, frothy discharge, itchiness, dysuria, and kind of a strawberry or beefy red cervix on examination. For that treatment of trichomonasis, this is metronidazole, which is an antifungal medication, antiparasitic medication, and treating sexual partners. For other upper reproductive tract infections, we have pelvic inflammatory disease. This is an infection of the uterus, fallopian tubes, and ovaries, usually caused by chlamydia or gonorrhea. Patients with pelvic inflammatory disease will have symptoms like lower abdominal pelvic pain, fever, abnormal bleeding, and cervical tenderness. This is where a provider will be examining the cervix through a pap smear, and they will have cervical tenderness. Complications of pelvic inflammatory disease includes ectopic pregnancies, chronic pelvic pain, and infertility. So for those patients with pelvic inflammatory disease, they will need rest and fluids, broad spectrum antibiotics, and treating those partners as well, and no sexual intercourse until that treatment is completed. Let's see, for our male in our male reproductive tract infections like epididymitis and prostatitis, these are usually swelling of the epididymis or the prostate, and usually treatment relies on antibiotics and rest. Always assess sexual history, any symptoms of RTIs, menstrual changes, risk factors, which would be multiple partners and no condom use, making sure that we do that in a non-judgmental way. For our nursing interventions with PIDs, usually what we will do is administer antibiotics or antivirals, educating the patient on completing their full medication course, abstaining from sex until that treatment is finished, making sure to treat partners for potential STIs or bacterial infections, reinforce use of barrier methods, and then promote screenings like your pap smears, HPV, and STI testing. For your STIs or sexually transmitted infections, these used to be referred to as STDs. These are infections that are transmitted during sexual intercourse or sexual contact through swapping or sharing of body fluids or different blood and body fluids. There are two different types. There are viral pathogens and bacterial pathogens. So treatment and symptoms kind of occur based on what those are. For our viral pathogens, these are HSV or herpes simplex virus, HPV or human papillomavirus, and HIV, human immunodeficiency virus. For these are a viral pathogen. So with those, they are not curable with antibiotics. We can strictly prevent them. So this is prevention with condom use. Some of them do have vaccinations. So HPV does have a vaccination within a certain age group, up to, I think it's 26 years of age now that they recommend that for reducing HPV. Some of these will have different signs and symptoms. So HSV is a lesion or an open sore. Usually this is multiple little open sores or can be one. These are usually painful during the time that the patient has that open wound. Avoiding the discharge or liquid that comes out of that wound would be the method of decreasing transmission. So ensuring that the patient abstains from any sexual intercourse or sexual contact while that wound is healing or that canker is healing does decrease transmission. For HPV, again, HPV in males is a silent infection. So oftentimes males don't even realize they are a carrier of HPV, and so they can transmit that to female partners. This is the most common cause of cervical cancer, HPV, and it also can cause genital warts as well, which is a flesh-colored or a non-painful growth on the genital area. For HIV, this is a viral infection that can lead to a destruction of our immune system, can lead to secondary infections or opportunistic infections, and can eventually lead to AIDS. For our patients with HIV, we want to identify viral load counts, looking at CD4 counts for our immune systems, looking at T helper cell counts to kind of get an idea of overall health. For our patients with any HIV or AIDS, we want to make sure that they abstain from unprotected sexual intercourse, sharing of needles, body fluids, and things like that. It is not transmitted through hugging, kissing, toilet seats and things like that. It's no longer transmitted through blood products or blood transfusions as of 1992. They do screen for that in blood products. Um, for HIV and other viral pathogens, medication adherence is very important. Patients should adhere to those antiviral medications. Oftentimes, they will take that daily for the rest of their life, especially with HIV or AIDS, and paying attention to those. We also can give PrEP, which is pre-exposure prophylactic medications. This is important for healthcare providers who might have an exposure like a needle stick or blood exposure, or patients who might be having unprotected sexual intercourse who may have come into contact with an individual who's infected with that virus. So again, with the PrEP, important education is adherence on that medication and taking that medication early once they think that they may have been in contact with somebody who has an infected, the infection. For our bacterial pathogens, these are gonorrhea, chlamydia, and syphilis. So for gonorrhea, your patient may have yellow, greenish discharge or a thick white discharge. They may have urinating, painful urination, and may have infertility. Chlamydia, same thing. They may have changes in their discharge, vaginal discharge, penile discharge. They may have infertility. They may have painful urination. For syphilis, syphilis is typically a single canker, open sore. It is oftentimes painless. It can occur on the hands and the feet as well, and have different systemic effects in later stages of that syphilis. So in late stage syphilis, patients can get those cankers throughout their body on different organs, and it can travel to the brain, where essentially their brain starts to deteriorate and turn into Swiss cheese. For those bacterial pathogens, obviously antibacterial medications, antibiotics, would be the method of treatment for that. So these would be things like penicillin, which would be given via IM injection. For our STIs, most common complications lead to infertility, pelvic inflammatory disease, and can also lead to neonatal infection during childbirth. Okay, so we're going to first talk about polycystic ovarian syndrome, or PCOS. This is a hormonal and metabolic disorder that is characterized by irregular ovulation, high male hormones known as hyperandrogenism, and polycystic ovaries, which are ovaries that have a bunch of cysts on them. Usually this is seen on ultrasound. It is frequent with PCOS, but is not the only requirement for diagnosis. For PCOS, this is driven by an insulin resistance. Increased insulin causes those ovaries to produce increased androgens. Those increased androgens disrupt the follicle maturation that we talked about previously and can lead to irregular or absent ovulation. So it's kind of a cycle. Insulin creates androgens, androgens create irregular ovulation, and ovulation or irregularities in ovulation lead to that menstrual dysfunction. For our cues, patients will have irregular periods. They oftentimes have ovaries that have many cysts on them found in ultrasound. They have higher cases of infertility. They will oftentimes have weight gain or central obesity. They will have darkened skin folds. This is called acanthosis nigricans. They also will have hirsutism, which is excessive facial and body hair. For long-term health risks, they have a higher risk for developing type 2 diabetes, hypertension, endometrial cancers, cardiovascular disease, and different metabolic syndromes. Our first line management is oftentimes weight reduction, eating a low glycemic index diet, and exercise, along with hormonal contraceptives. This helps to regulate the cycles and lower androgen levels. Metformin can help to improve insulin resistance and restore ovulation. And then medications that induce ovulation, like Clomid, is important for infertility. For these patients, it's important to teach cycle regulation, monitor for metabolic syndrome, and then support their mental health, since PCOS can lead to infertility. When we look at endometriosis, this is the presence of endometrial tissue on the outside of the uterus. This is commonly found on the ovaries, fallopian tubes, and occasionally the bowel or bladder. Because this is endometrial tissue, it responds to hormones, so it can cause bleeding, inflammation, scarring, and adhesions. So what we will clinically find, or our patient cues for endometriosis, is the classic triad. This is severe dysmenorrhea, so that out of proportional, painful menstruation, chronic pelvic pain, and dyspareunia. This is pain with intercourse. These patients will oftentimes have irregular bleeding, infertility, and painful bowel movements as well. So for these patients, to diagnose PCOS, or I'm sorry, endometriosis is what we're on. To diagnose endometriosis, we will look at symptoms including pelvic pain. A transvaginal ultrasound might be used to show the epithelial tissue lining outside of the uterus, so ultrasound. But a laparoscopic camera is typically the gold standard to be able to visualize the lining outside of the uterus. For our nursing considerations, we want to educate on the chronic nature of the disease, discuss infertility methods, provide emotional support, and then validate the pain. Oftentimes, endometriosis pain is minimized and kind of pushed to the side. For your patients with endometriosis, just remember to do a good assessment for menstrual cycle irregularities, and assess for that pelvic pain and pain with intercourse. So for our lecture, we will talk about hysterectomies. This is the most common gynecologic surgery and is oftentimes performed for different benign or malignant conditions. There are a few different types of hysterectomy, or surgical removal of the uterus. One is a total hysterectomy. This is a removal of the uterus and the cervix. The ovaries and tubes typically remain, and this can be used for different problems related to the uterus or cervix itself. For our total hysterectomy with our bilateral salpingo-oophorectomy, that's a big Jeopardy word. This is a removal of the uterus and the cervix, but also removing the fallopian tubes, which is the salpingo part, and the ovaries, which is the oophorectomy part. If ovaries are removed, surgical menopause occurs immediately. For our radical hysterectomy, this is a removal of the uterus, cervix, upper portion of the vagina, surrounding lymph nodes, and tissues surrounding. This is primarily used for gynecological cancers for the patient. When we are looking at surgical approaches, sometimes these can be done through an incision in the abdomen. It can be done through the vaginal opening, so the incision is in the vagina, or done laparoscopically with robotic assistance. Both the vaginal hysterectomy and the laparoscopic hysterectomy are less invasive, a faster recovery, and less pain. For our benign causes of hysterectomy, these would be things like endometriosis or chronic pelvic pain. Excuse me. Sorry, I felt like I was going to sneeze. The most common benign causes for hysterectomy are uterine fibroids, endometriosis, or abnormal uterine bleeding. For our cancer related, these would be things like cervical cancer, endometrial cancer, ovarian cancer, or reduction of genetic risk. For our pre-operative care, it's going to be very similar to most surgical procedures we have, getting consent, doing your discharge or post-op treatment, and then any bowel prep is needed since they'll be in that, in the abdomen area. They also will do a pregnancy test prior to surgery just to make sure that the individual is not pregnant. For your post-operative nursing care, we want to focus on pain management. It depends on which route they did. Patients will have more pain typically with abdominal removal versus vaginal or laparoscopic, but making sure to be aware of need for analgesics. We also will want to monitor for complications. This is pretty much the same as most surgical procedures. So things like infection, urinary retention, DVTs, bowel and bladder injury, or hemorrhage. For your patients, they may have some small vaginal bleeding afterwards. This can be normal, but if it is heavy, bright red bleeding, this would be an abnormal finding and you would want to notify the doctor. For our activity restrictions, they should have no lifting greater than 10 pounds for about 6 to 8 weeks, no intercourse for 6 to 8 weeks, no tampon use or douchings as well. Some patients may have a catheter, so just remember our catheter care for indwelling catheters and do that appropriately. For our surgical menopause, this is done if those ovaries are removed. Remember, these symptoms will occur suddenly. Symptoms are oftentimes more intense since it is like an immediate abruption of the menstrual cycle. So they may have those hot flashes, night sweats, mood changes, vaginal dryness, and bone density loss. So patients may need to consider hormone replacement therapy if appropriate, use weight-bearing exercises and encourage calcium and vitamin D, and then discuss sexual health and the use of things like vaginal estrogen or lubrication. For our psychosocial considerations, women may experience grief due to the loss of fertility, body image concerns, intimacy concerns, and fear of cancer reoccurrence if that is why they had it removed. So not every patient wants to have a hysterectomy. It's not just a decision, oh, I'm done having children, I'm going to have a hysterectomy. Some individuals may lose it when they do not want to have that removed. So just making sure that we validate feelings, offering counseling resources, and providing education. If the cervix remains after a hysterectomy, pap smears would still need to be done since they are still at risk for that cervical cancer. So just making sure that we educate on that as well. Here are the objectives for chapter 52. For our breast disorders, I'm going to break it up into benign and malignant breast disorders. So first, we're going to talk a little bit about malignant breast cancers and tumors. So up in the top left corner, we want to make sure that we educate and assess for any lumps on a patient's breast. This can occur in male and female patients since male patients also have breast tissue. So make sure that we educate on feeling for any lumps. Typically we do this through self breast exam. We educate, making sure that the patient does this every month, oftentimes in the shower, when that breast tissue can be a little bit more manipulated a little bit easier. And we avoid doing breast exams during menstrual cycle or before menstrual cycle, since lumps can be due to hormonal changes related to that. What you want to educate on is the individual will palpate their breast tissue from starting at the nipple, working their way around the breast tissue up into the armpit. So in that diagram there, you can see that there is lymphatic system and lymph nodes up in the axillary armpit area. And so we want to palpate for any enlargement of those lymph nodes, any lumps in that breast tissue. For our other signs of potential breast cancer or malignancies, over in the right-hand side of the slide, you're going to educate the patient to stand in front of the mirror, looking at their breast bilaterally and making sure that there's no changes in the tissue on their breast. So they're looking for any lumps that they can see, any dimpling or changes in the skin, changes in the skin texture or color. So oftentimes breast cancer will be referred to as orange peeled skin. So if they see that, that could be a sign of breast cancer. Changes in how the nipple looks itself. So any inversion of the nipple, pulling of the nipple, or changes in the shape of the nipple, and any discharge of the nipple as well. So bloody fluid that leaks out of the nipples, clear fluid that leaks out of the nipple, is sometimes a sign of breast cancer, and they would want to get assessed. When we look at staging breast cancer, because cancer is a specialty, we won't go too far in depth, but they do use the TNM system for breast cancer staging. So T stands for tumor size. So you'll see there different levels of stages based on how big the tumor is or that lump is. N stands for lymph node involvement. So this is where lymph nodes are involved, or if it metastasizes through the body. Lymph node involvement, and then M stands for metastasis. So this is if the cancerous lump or area is defined to one space, or if it metastasizes through the body. We also can look at genetic characteristics or a genetic DNA related to breast cancer. So those are your genes, BRCA1 and BRCA2. Those are the genetic genes that we will test for and see if a patient has a risk factor for developing breast cancer. So this is a blood draw. They can look at this and see if an individual is at risk for developing this. This is typically reserved for patients who have high risk for breast cancer. Maybe they have a family history of breast cancer, and so they can have this drawn, and it will tell them if they do have a risk for developing breast cancer because they have this gene in their genetic DNA. Angelina Jolie was one of the famous people who did this, and she chose to have a radical mastectomy, have her breast tissue removed because she was a carrier of this, and her mother had breast cancer as well. So she chose to just have a mastectomy as kind of a preventative measure. When we look at tumor care or lumpectomies, removal of lumps, this is going to be your 3 different types. So there is the lumpectomy. So this is where they will remove just the lump itself. That's a smaller area of tissue and a smaller removal. Oftentimes they'll do this if they have a lump that they've determined through a biopsy is cancerous, and that's just removal of that tissue. They usually will do what's called removing of the margin, so that's the tissue around the lump, just to make sure they get every single cancerous cell. In the middle there is the total simple mastectomy. This is removing the breast while keeping the pectoralis muscle intact and the area of the armpit or axillary area with the lymph nodes. Then you have a modified radical mastectomy. This involves removing the breast and the axillary lymph nodes and tissue, and leaving the pectoralis muscle intact. For your radical mastectomy, this is a removal of all breast tissue, all axillary lymph nodes, and pectoralis muscle itself as well. So that is your most drastic removal of breast tissue. Okay, so now we're going to talk about some benign or non-cancerous conditions of the breast. These sometimes mimic breast cancer, so that's why we want to educate the patient on early detection and kind of identifying if these are cancerous or not. They are most common in younger menstruating women and are usually hormonal related, and so they can cause things like pain, structural changes, and lumps. So we're going to talk about fibrocystic breast changes. So fibrocystic breast changes up in the top right corner. This is our most common benign breast condition. This is characterized by cyst formation, things like fibrosis or scar-like tissue buildup, and can have a lumpy or rope-like texture in the breast. This is typically triggered by estrogen and progesterone fluctuations during the menstrual cycle. So patients will have some breast tenderness or pain that's oftentimes worse before their period starts or their menstrual cycle. Usually the lumpiness occurs in the outer quadrants, but they can have swelling or possible green-brown discharge that can occur. Typically the pain will improve after menstruation. Use of supportive bras, warm and cold packs can help with swelling. Use of NSAIDs can help with pain as well. For our patients with fibroadenomas, so fibroadenomas are kind of a firm, rubbery, mobile, which means they're movable, well-defined mass in the breast. This is most commonly found in young women, adolescents under the age of 30. Symptoms are often that painless lump. They move easily under the skin, and they are usually round and have well-defined edges. For our treatments, most oftentimes they will just monitor this with repeat ultrasound imaging. They can do a needle biopsy if the diagnosis is uncertain, but oftentimes they will just monitor it and watch it. They might do surgical removal if it is large enough or if it's causing other symptoms, so kind of a palliative removal. For breast cysts, these are fluid-filled sacs within the breast tissue. These are often smooth, round, and mobile. They can be tender, and size usually will fluctuate with menstrual cycle. So they might feel like a grape or a water balloon under the skin. Ultrasound usually differentiates between a solid versus a fluid-filled or cystic mass, and a needle aspiration can relieve discomfort if needed. But for the most part, there is no treatment if the individual has no problems with it. For mastitis, mastitis is most common in breastfeeding women. This is an infection of the breast tissue. This usually occurs from that milk being stagnant in the milk ducts. Patients will have a redness or a warmth to the breast tissue. They may have a localized painful mass. They may have fever that occurs due to the inflammatory process, and will typically get worse if patients do not continue breastfeeding. So treatment is to do a warm compress, continue breastfeeding and pumping more frequently on that side, and utilize antibiotics if needed. Then we have a breast abscess. So this can be a localized collection of pus. This oftentimes follows mastitis. Patients will have a severe localized pain. They may have a mass that is palpable, may have redness or swelling of the breast tissue, and then may have systemic fever. For these patients, incision and drainage or removal of that fluid is typically the first method of treatment. Antibiotics would be the second, and then increased pumping on that side for removal of milk if that is the cause of that mastitis. For duct ectasia, so this is a dilation of the breast ducts, which leads to inflammation. These patients may have a thick, sticky nipple discharge, oftentimes green or brown, nipple inversion or tenderness. For our treatment, these would be warm compresses to kind of open up those ducts a little bit, decrease inflammation, and antibiotics if needed. For our breast problems, typically what we're looking for is if we have a persistent lump that does not fluctuate with menstrual cycle, if it is a hard, fixed, irregularly shaped mass, if there's any bloody or changes in nipple discharge, orange peeled skin nippling, nipple retraction, or any non-lactational mastitis. These could possibly be a malignant disorder. Other than that, what we're looking for is soft, non-tender lumps that are movable, that have well-defined borders, and no changes in discharge or texture of the breast tissue. And that would usually show that it's a benign abnormality. So we have talked about chemotherapy and radiation in the past when we talked about our oncology lecture. But just remember, radiation can have impact to the skin, so we want to make sure to keep that skin clean, dry, not use any lotions or perfumes. We can use a little bit of aloe vera gel if we have skin irritation due to radiation beam therapy. And typically, this is just like an extreme sunburn, is basically how you would want to treat that skin. For chemotherapy, remember, chemotherapy kills all cells, not just cancerous cells. So we have a lot of systemic effects, excuse me, in relation to those destruction of cells throughout the body. So we may have anemia, respiratory problems, neutropenia, changes in immune function, and things like that. Here in the top right, this is a picture of a mammogram. So this is your ultrasound of your breast tissue. This is typically recommended at age 40 if a moderate to low risk for the patient. If they're at high risk, they will do those mammograms earlier just to get a baseline of breast tissue. So it's an ultrasound of the breast tissue. It clamps the breast down. Most commonly, patients or women complain of it just being discomfort since the breast tissue is kind of slammed between the two plates. But just positioning is really just the discomfort that that patient might have. It's non-invasive, so it's just pictures of the breast tissue itself. For patients with larger breast or fibrocystic breast tissue, they may not get a good picture, and so the next option would be a needle biopsy or an ultrasound, and then if they find any lumps, then they would do an ultrasound guided needle biopsy, which is the bottom picture there. So that would be where they use an ultrasound to find the mass, and then they insert a needle to aspirate some of the cells of that lump to see if it is cancerous. Here are the objectives for chapter 53. Okay, so now we're going to talk about male reproductive disorders and the male reproductive system. So for this picture, you will see that they will have the penis, the scrotum, epididymis, the vas deferens, and the prostate. Those are mainly the parts of the system that we're going to talk about. Okay, so now we're going to talk about BPH, or benign prostatic hyperplasia. BPH is an enlargement of the prostate gland that is non-cancerous, and it typically occurs in older males. As this prostate enlarges, it starts to compress the urethra, which leads to lower urinary tract symptoms. It is most commonly in men age 50 years of age and older. As a patient ages, this does increase their risk of developing BPH. Hormonal influences like testosterone levels can also play a factor into this inflammation or enlargement of the prostate gland. For our patients, your clinical findings or clinical manifestations, your cues, they are going to be things with obstructive symptoms. So symptoms of that urethra being blocked. So that could be things like them feeling like they don't completely empty their bladder. They have intermittent flow or a weak stream, like dribbling urine. They strain to void, or they have hesitancy. They may also have nocturia, which is excessive urination at night, excessive urinary frequency or urgency, and they may have mild dysuria. The problem with this is that it can block that urinary system and the urine coming out of the urethra and lead to acute urinary retention, which can have problems with fluid overload, electrolyte imbalance, and things like that. So for our diagnostics, typically we will do a post-void residual scan to see if there is urine left after the patient voids in their bladder. We may also do a digital rectal exam to palpate for the prostate. And what we want to see or what we want to feel is a small prostate, but with BPH, they will feel an enlarged prostate that is typically smooth and non-tender. They can also do a prostate level, so a prostate antigen level for blood. This can be mildly elevated, but it's not typically used to diagnose cancer. They will also do a urinalysis to rule out any infection. So for mild symptoms of BPH, what we'll do is we'll avoid fluids in the evening, limiting caffeine and alcohol consumption, and just do like kind of avoiding schedule or toileting schedule, and just managing symptoms, making sure that the patient is still urinating. We can give medications like alpha blockers that help to relax the bladder and the neck and decrease that prostate muscle from contracting. These medications would be tamsulosin or Flomax is the name that you'll typically see used for your patients, or terazosin. With this, if we give medications that help decrease the bladder neck muscle contraction, then we would want to watch for excessive urination, which may cause orthostatic hypotension. We also can do alpha reductase inhibitors like finasteride. These help to shrink the prostate by decreasing DHT. These medications do typically take about 6 months to take full effect, and it can decrease libido in a male patient. So we want to make sure to educate on that the patient should continue to take these medications. These medications can also be toxic to pregnant women, so make sure to protect yourself with gloves. If the prostate is enlarged continuously, the patient's having a lot of problems with urinary retention, they can do a surgical procedure. That surgical procedure is in the bottom left-hand corner. That is called the transurethral resection of the prostate. So trans means inside, urethral means through the urethra, and then resection means to cut away or resect, remove some of that prostate tissue. So the TURP is the gold standard surgery for moderate to severe BPH when medications are not working alone, and it is a procedure that is somewhat tested on NCLEX. So the TURP procedure is through the urethra. That way there's no external incision, and they will go in with laparoscopic cameras and little clipper things and remove the excess of that prostatic tissue that's blocking that urethra. This helps to reduce that urethral obstruction. Most of the time, your testable material related to a TURP procedure is relating to post-op care. So your patient will get a continuous bladder irrigation. So that's that large 3-way Foley catheter inserted. One port drains the urine, one inflates the balloon, and then that third one is where they do continuous irrigation with big giant bags of fluid. That helps to prevent clot retention. For this, your main nursing priorities are to monitor urine output. What you want to see is that they maintain a pink to light red urine. They should not have a dark red urine or clots. If that's the case, that flow of that irrigation needs to be increased. If it's all the way open and flowing as fast as it can go and as much as it can go, then that would be something to notify the doctor. Never let that catheter become occluded, or else all that fluid is going to back up into the bladder and can actually cause the bladder to burst. So with your patients with a CBI, they're usually filling up a Foley bag about 15 minutes. That bag will fill up when you're wide open. So pretty heavy, busy patient with a continuous bladder irrigation. We also want to make sure to monitor for pain and bladder spasms. This is common after a TURP procedure. So we may give antispasmodic medications like oxybutynin. We also want to look for bleeding. So again, small bleeding is somewhat to be expected, so monitor for your urine output. But if you see any bright red bleeding or large clots, you want to call the doctor. We also want to do activity restriction, so no sexual intercourse for 4 to 6 weeks, avoid heavy lifting, and then because that prostate runs right alongside of the rectal cavity and the rectum, we want to make sure the patient does not get constipated, since excessive stool and straining can cause pressure on that surgical site and can actually cause bleeding from opening up of that incision. Burning and urgency might occur for about 4 to 6 weeks after a TURP procedure. They might have a little temporary urinary incontinence, but they really need to make sure to take stool softeners, increase fluid intake appropriately to flush out the bladder, and then also avoid bladder irritants like caffeine and alcohol, so that they can have a good healing area there with that surgical site. So complications to watch for: bladder spasms, infections, catheter obstruction, hemorrhaging, and any problems with the continuous bladder irrigation. Okay, so we're going to talk about erectile dysfunction. This is the inability to achieve or maintain an erection enough to have satisfactory sexual performance. So it's common, especially with elderly patients or aging adults, and it might be caused by either vascular problems, neurological problems, hormone problems, psychosocial factors, or medication-related factors. So basically what occurs is the arterial blood flow into the penis is impacted, and there is not enough adequate blood flow to occur to get an erection. This can occur from inadequate testosterone, nerve pathways that are damaged, vascular causes. Vascular causes are the most common cause of erectile dysfunction. This can be things due to smoking, peripheral artery disease, hypertension, diabetes, arteriosclerosis. Neurological causes would be things like a spinal cord injury, stroke, or MS, which we talked about in neuro. Hormonal causes would be pituitary and thyroid disorders and diseases, low testosterone levels. Common medications that can cause erectile dysfunction are going to be beta blockers, SSRIs, antipsychotic medications, and anti-androgen therapies. And then your psychogenic causes can be stress, anxiety, relationship difficulty, and those sorts of things. So nurses need to make sure that they address both physical and psychosocial contributing factors. For your diagnostics, we'll do a basic evaluation. So this is typically patient reports problems with getting an erection, and you'll gather that during your medical and sexual history assessment. We can get a testosterone level to see if that's a factor that plays into it. We can do a glucose level or A1C, which ties into that diabetic screening, or we can do a lipid panel. For your specialized urological testing, this would be an ultrasound of the penile blood flow to look for obstructions, or looking at penile tumescence testing. This helps to look at the blood flow and the muscle flow and everything related to an actual erection. So our first line of management is lifestyle modifications. So making sure we decrease smoking, weight loss, exercise, do good blood pressure control, since erectile dysfunction is usually an early sign of cardiovascular disease. Our first line therapy for medications is going to be a PDE5 inhibitor. This is your typical medications like sildenafil or tadalafil. This is your Viagra and Cialis. These help to enhance blood flow by relaxing that smooth muscle in the penile arteries and help to create that erection. For your NCLEX testing, this is usually tested very heavily on NCLEX. We want to make sure that they don't take it with nitrates, medications like nitroglycerin. This is because that can create life-threatening hypotension, since both of them are a vasodilator. We want to make sure to use caution with any alpha blockers. Take about 30 to 60 minutes before sexual activity. and just make sure that the patient is really safe with that. So big testing thing is do not take with nitrate medications. We can do testosterone replacement if testosterone is low, but we want to monitor our patient on that. We can do mechanical or procedural treatments, things like penile injections, penile implants, or vacuum erection devices. So since erectile dysfunction can cause patients to have relationship distress, body image concerns, anxiety, and depression, we want to make sure to be supportive, use non-judgmental communication, and then educate about the causes and treatments for erectile dysfunction. Okay, so we're going to talk about some additional reproductive health issues in males that you might be tested on or might see. So we're going to start with prostatitis. So this is an inflammation of the prostate. This can be a cancerous growth or it can be that BPH that we talked about. But for the most part, this is an inflammation of the prostate, and we will evaluate that through a digital rectal exam and then do medications like finasteride or Flomax, and we will monitor for urinary retention. Paraphimosis, this is where an uncircumcised male will have problems with their foreskin. So if you see in the picture here, number A or letter A is a normal uncircumcised penis. That foreskin covers the urethral opening area, and that is what it normally looks like. When you retract that foreskin back, if you don't put it back the way it's supposed to be and it's pulled back over the tip of the penis, like in picture B, what can actually occur is swelling and inflammation of the foreskin around the tip of the penis, and it can actually start to cause constricting of the tip of the penis. So this is why in fundamentals lab, when you were doing a Foley insertion on a male patient, if it's an uncircumcised patient, you would want to retract the foreskin, clean, insert the Foley, and then make sure to pull that foreskin back in its natural position. Otherwise, you can get paraphimosis, which can constrict the blood flow to the tip of the penis. For your patient down at the bottom there, phimosis, this is actually, this is what can occur with an uncircumcised male, where that foreskin will actually kind of grow around the tip of the penis to where that foreskin cannot be pulled back. For these patients, usually they'll have to do surgical circumcision and remove the foreskin so that the penis can move freely and that there's no problems with that. For our epididymitis, so this is an inflammation or infection of the epididymis. This is the coiled tube that's behind the testicle that helps to store and transport sperm. Typically, the common causes for this in men that are sexually active is our STIs, chlamydia and gonorrhea. In our older men, this is usually related to UTIs and the E. coli bacteria. It can also occur from urinary catheters or a secondary infection from that prostatitis. For our clinical manifestations of this, typically it's a gradual onset of scrotal pain, usually about, a couple hours to days. What they will find is a unilateral swelling or warmth and tenderness in one of their testicles. They may have fever and chills, signs of inflammation and infection. They might have urinary symptoms related to frequency or dysuria. Typically, the pain improves with elevation of the scrotum, and so that way we would know that it was the epididymitis. We can also diagnose it through STI testing, a scrotal ultrasound to rule out our next discussion, which is testicular torsion, and a urinalysis, which will oftentimes show an infection. So if it is STI related, we're going to give antibiotics. If it's UTI related, we'll give antibiotics like levofloxacin. In general, we'll do scrotal elevation, some NSAIDs, rest, abstain from sexual activity, and apply some ice packs to help with inflammation. For our testicular torsion is actually a medical emergency This is where the scrotum and the spermatic cord will actually become twisted. Sometimes this can occur from like a trauma, like getting a football thrown to the testicles, not our testicles, the testicles, and can actually be sudden as well. So it can just be something that spontaneously occurs. For testicular torsion, the patient will have sudden severe pain, and that pain does not go away when the scrotum is elevated. They will have no urinary symptoms, and that pain just is not relieved. So for that patient, this is an emergency. We would want to notify the doctor, and also the testicular torsion, utilizing an ultrasound, we're able to see that that spermatic cord is twisted. So recognizing those emergency signs and recognizing those cues, keep that patient NPO, and get them into the OR. And so they'll do surgery on that. So typically the way you can tell testicular torsion versus epididymitis, the torsion is usually in younger patients. That pain is intense versus kind of a constant pain. It's a sudden, severe, intense pain. They don't have any urinary symptoms. They have some nausea and vomiting, and they will be in a lot of pain. So that's usually what we will assess for. And here are your objectives for Chapter 54. So we are going to talk about LGBTQ plus health, kind of talk about how to communicate with our patients, how to give them an inclusive experience with their healthcare, and make sure that they get healthcare that they need, and make sure that they feel part of the healthcare team. So LGBTQ plus stands for lesbian, gay, bisexual, transgender, queer or questioning, and others. So it's kind of an all-encompassing umbrella. It helps to represent diverse identities and experiences. So sometimes we're looking at what an individual identifies as versus what they are genetically born. For this group of individuals, we want to make sure that we build that patient-nurse relationship that's built on trust, making sure that we identify health inequities, making sure that we provide an inclusive environment of care to make sure that those individuals are able to seek adequate health care, they feel comfortable, and they feel included in their treatment. So for our terminology and key concepts related to LGBTQ plus health, we're going to talk about a couple terms that are good to know. So sexual orientation refers to a person who is emotionally, romantically, or sexually attracted to a different person. So this is who an individual has an attraction to. So an example of this would be lesbians, gays, bisexuals, or pansexuals. When we talk about gender identity, this is a person's internal sense of being male, female, or both. Could be an internal sense of not really having a gender or being gender fluid. Examples of this would be gender fluid, transgender, or non-binary. For gender expression, this is an outward presentation of gender. So this is what an individual uses with their appearance, clothing, or different mannerisms to express what type of gender that they identify as. We then have our gender or our sex that's assigned at birth. This is a biological distinction of either male, female, or intersex. This will be what we utilize in relation to different disease processes. So, somebody may identify as a certain gender, but we do need to assess their sex assigned at birth to give different designations related to disease factors or disease processes that can affect one gender over the other. Then we have our chosen name and pronouns. So name and pronouns reflect a person's identity. And so typically nurses, we want to use the patient's chosen name and pronouns, even if they differ from the gender or the name assigned at birth. And we're going to go a little bit more into the gender and sexual orientation and identity and expression throughout the lecture. So again, when we're looking at some of the disease processes or genetic disorders, we do have to pay attention to the sex gender of an individual, so which biological characteristics they have. This relates to which hormones they have in relation to the anatomy that they have when they were born, and different chromosomal disorders or different chromosomal disease processes that you'll see. For our gender, this is usually a physiological identification that we look at when we're treating disease processes, but it can now be a social construct where people identify as different genders from what they were genetically born with. For our orientation, we always want to pay attention to different orientation kind of characteristics because we want to always understand an individual's emotion, romantic, or sexual attraction, just to kind of ask if it impacts disease processes. So again, our gender identity may align with genders that an individual is born with, but it might differ from the sex or gender that's assigned at birth. So we always want to ask the patient what pronouns they prefer, ask, if they identify as the sex that they were assigned at birth, ask if they have any type of different genders like non-binary, genderqueer, or gender fluid, which would be a way that they would express themselves and would be preferred to be identified as in the hospital. So for this population, they can have different types of health disparities. Oftentimes, a lot of them are common in this population, things like mental health disparities, higher rates of anxiety, depression, suicidal ideation, especially in the youth of the LGBTQ plus community. They can have higher rates of sexual and reproductive disorders like STIs, HIV. This is oftentimes due to a feeling of inability of getting adequate care. So maybe they're embarrassed or they don't want to talk about things that may be overlooked in society, and so they will not seek care when exposed to different things like STIs or sexual health. They also will have different disparities related to contraceptive use. So contraceptive counseling is often overlooked for individuals who may be trans men who can still become pregnant or queer women. For our patients in this population, they will have a higher risk of chronic diseases. These things like cardiovascular disease, obesity, diabetes, tobacco and alcohol use can often be due to stress, high levels of stress, and healthcare avoidance. For our transgender individuals, they have a higher risk of things like hormone therapy affecting their needs or changing their metabolic processes. They have a higher risk of cardiovascular changes, especially upon estrogen, a higher risk of red blood cell production, so increased red blood cell production if on testosterone, and then higher risk for post-operative needs after gender-affirming procedures. For our LGBTQ population, a lot of the barriers to care that people frequently report are things like negative healthcare experiences, lack of provider knowledge, fear of discrimination, individuals either misgendering or incorrectly pronouncing them or using pronouns, and then different types of privacy concerns as well. So again, these are the barriers to care for this population. Nurses have a direct impact on breaking these barriers, oftentimes through communication, asking questions to the patient, asking really good questions to understand what they're looking for in their care. So fear of discrimination or mistreatment, lack of knowledge, provider knowledge, excuse me, inadequate insurance coverage, limit to culturally competent care, higher risk of that, suicidal ideations, bullying, homelessness. They have barriers to adequate sexual and mental health care that is needed, and then need for a safe school and clinical environment. So nurses can help break these roles by using inclusive language, assessing their safety and their mental health, assessing sexual health in an open and non-judgmental way. Okay, so while they are at higher risk for STIs and HIV due to, inability to access quality care or non-judgmental care, we don't always want to assume that they are at higher risk for HIV or STIs. We want to screen them based on their risk factors. So asking questions if they have one partner, multiple partners, do they use, barrier methods like condoms or contraceptive use, those kinds of things, assessing their risk factors. Once we identify a high risk patient, we want to educate them on the use of PrEP and PEP and the use of condom or barrier methods. Making sure that we educate them on appropriate sexual health screenings, regular screenings, and just having open discussions in a non judgmental way. For our nursing interventions, to be able to create an affirming environment, we want to make sure to assess and ask what chosen name and pronouns the patient has, and use those names and pronouns. Provide inclusive intake forms, provide gender neutral restrooms, non-discrimination policies. We can ask questions in a non-judgmental way. So instead of asking things like, do you have a husband, or are you married? Do you have a wife? Ask if they have a partner. That way it covers all different types of identifying characteristics or words. Screen based on organs present, not gender identity. Make sure that we identify any hormone therapy or medications, and never assume sexual behavior based on identity alone. So really just ask questions, ask the patient in a non-judgmental way, allow them to be able to talk about, their gender identity, their sexual identity, sexual orientation, and things like that. For our nursing interventions, to be able to create an affirming environment, we want to make sure to assess and ask what chosen name and pronouns the patient has, and use those names and pronouns. Provide inclusive intake forms, provide gender neutral restrooms, non-discrimination policies. We can ask questions in a non-judgmental way. So instead of asking things like, do you have a husband, or are you married? Do you have a wife? Ask if they have a partner. That way it covers all different types of identifying characteristics or words. Screen based on organs present, not gender identity. Make sure that we identify any hormone therapy or medications, and never assume sexual behavior based on identity alone. So really just ask questions, ask the patient in a non-judgmental way, allow them to be able to talk about, their gender identity, their sexual identity, sexual orientation, and things like that. And here are your NCLEX questions to go over the concepts from this lecture.